just outlined. I started my surgical consultant post at Epsom and St Helier in 2004, when there was no foot and ankle service. And I'm really pleased to report that over the past 17 years, our foot and ankle service has grown immensely. And we are serving a huge load of population around all of Southwest London and Surrey. We are now 3 consultants, and you may have met one of my colleagues, Mr. Hamilton, already. There's another colleague, Mr. Yusuf, and there's myself. We also run a BOA fellowship with the British Orthopaedic Association Future Leaderships Program. We've got 2 trainee registrars, and we've got a research assistant. We're contributing hugely to research, and as part of service development and training, I started to develop my interest in minimally invasive surgery back in 2009. And I will give you in my talk a few examples of what can be done. I obviously also undertake all sorts of open surgery, whether it is toes or hallux valgus, whether it's bunionets, midfoot arthritis, or ankle ligament repairs, ankle fusions, and a whole lot of it. So I'm also, for all my sins, the medical director for the division of planned care. So I'm hugely involved in getting the pathway for our patients better, getting the treatment to our patients for which they have waited so long, particularly over the past 15 months. And I'm incredibly happy to be here tonight. If it is okay, I will share some slides with you. And it should take no longer than possibly 15-20 minutes. I will share a couple of resources with you, and we will then have opportunity to take questions. By all means, if you have questions in between, please put them in the chat, and Budin will facilitate me answering those questions, because I might be focusing on my slides a little bit. I'm going to start sharing my screen now with you, and we're going to, oh dear, there it goes. Can everybody see that? Budin, is that visible?
Yes, and you can
Lovely.
slideshow now, and then that will. So
I'm just going to go into the presentation mode now.
Brilliant.
Can you still see that? And can you hear me?
Perfect.
Okay, super, super. So thank you so much for asking me. I found this first slide was particularly impressive because it has got all the 4 acute care providers in Southwest London. And I'm really excited to be here because it means having a really broad audience covering all of Southwest London. And as you know, we are working so much more as a network, and it is in everybody's interest and in our patients' interest to streamline our pathways and be aligned on how we treat our patients for the most common conditions. So I am Andrea Sott, and as I have already said, I'm a consultant orthopedic surgeon. I still undertake trauma work, hip fracture work, and everything else, but I do specialize in foot and ankle. And in my spare time, I do a little bit of medical management. Hallux rigidus, or hallux limitus, is a progressive, degenerative, painful, stiffening condition of the big toe joint. And I'm sure you all know that. So I don't want to dwell on too much on definitions. I'll show you a few pictures and a few slides. And hallux rigidus can actually present in all sorts of ways. And sometimes it's barn door, and sometimes it's a little bit more subtle. How do patients develop hallux rigidus? So the etiology is primarily degenerative. So primary osteoarthritis on the background of possible overuse, excessive forefoot overloading, excessive athletic activities. I have to say at this point that my husband suffers from hallux rigidus, and he used to be a 1500-meter sprinter at Olympic level. So that's the price he's paying. And he does not take any advice from me, I can tell you that. Trauma to the intra-articular surface of the metatarsal head or the proximal phalanx, turf toe conditions, any damage to the cartilage as in osteochondral defects, and then slightly less important, less frequent conditions which involve neuromuscular imbalance, long first raise, or hypermobility. All of these can lead to hallux rigidus and stiffness of the big toe joint with pain and inability to wear shoes and carry out your activity of daily living. But mainly it's primary osteoarthritis. Biomechanics of the first, I'm sure that all of you being first care practitioners, GPs and physiotherapists and healthcare professionals know more than I do about it. But, you know, when you walk, you use your big toe, if it's normally aligned, to provide the toe off in the late stance phase. And as you toe off and as you lift, you can actually as much as transfer 4 to 6 times your body weight through that tiny joint in the big toe. In fact, yeah, 6 times body weight, it says here. A stiff joint does not allow for proper toe off and therefore forces the foot into a degree of supination or lateral overloading. And we call this an anthalgic supinated gait. And you can see that really well in your patients. If you watch them barefoot walking, if somebody presents with hallux rigidus, you will automatically watch them not loading their medial arch and their medial ray and their first ray. They will always try and walk on the lateral aspect of their foot because it is less painful. In terms of symptoms, when patients present to us in the foot and ankle clinic, we notice mainly 3 aspects of their complaints. The first one is pain. The second one is function. And the third one is deformity. You can pretty much deduce all presenting complaints to those 3 headings. Patients have pain because there's inflammation, cartilage degeneration, the nerves are overfiring, there's swelling, fluid accumulation, and it's just sore. The function is impaired because the joint is stiff. And as I said in my previous slide, they can't properly walk, they can't toe off. And sometimes the deformity of the osteophyte formation is so severe that they can't wear any shoes. And in fact, I've seen many patients that have come in with their shoes and they've actually cut a hole in them. So they cut a hole in the top of the foot, in the top of the shoe, sorry, to accommodate the osteophytes, which I will demonstrate to you in a couple of photos which I have prepared. Deep joint symptoms in terms of pain, this might be pain after exercise, pain the next day after exercise, sometimes even rest pain with advanced arthritis. When you look at a foot or a patient that you're suspecting of suffering from osteoarthritis of the big toe joint, you often notice generalized swelling around the first metatarsophalangeal joint. Very frequently, you can also see a dorsal bony prominence. You might notice some plantar callosities on the plantar surface of the 2nd, 3rd, 4th, and 5th metatarsal head. And that is due to the transfer metatarsalgia or overloading because they simply can't bear to walk on their big toe joint. On feeling, and I'm afraid this slide is not particularly impressive, it'll get a little bit better. You can feel a dorsal bump, an osteophyte. On moving, you will feel a decreased range of movement to the big toe joint. And it is always important to remember when you look at a foot and you move the big toe joint that the axis of the first metatarsal is not parallel to the sole of the foot. The axis of the metatarsal is slightly plantar flexed. So if you bring the big toe into truly neutral, as into 0, and you then attempt dorsiflexion, you will find that true dorsiflexion in hallux rigidus is extremely reduced. And we measure it as you do from 0 to 20, 30, 40 degrees. You occasionally find a hyperextension in the IP joint because they can't extend and dorsiflex their MTP joint. They have to compensate by hyperdorsiflexing the interphalangeal joint. And that in itself gives many problems, arthritis, and that is much more difficult to treat. The grind test is a test that we perform in the mid-range where we apply axial pressure, grinding the big toe against the metatarsal, and that can sometimes give symptoms when there is mid-joint symptoms present, rather than just osteophytes. And then you've got the impingement, which is due to dorsal and plantar osteophyte formation. And that again restricts the movements. So here is a range of movement from neutral, dorsiflexion, and plantar flexion. The grind test, this is what I was trying to say, is the axial load application to the joint in neutral. After our physical examination, and history taking, we often send the patient for an X-ray, or almost always. And we have a foot series which consists of an AP, a standing AP, a standing lateral, and an oblique. I did not put an oblique in here because it is not particularly helpful to me for hallux rigidus. But if you look at the AP radiograph here on the left, you can see all signs of osteoarthritis. Just to recap, the general signs of osteoarthritis are joint space narrowing, sclerosis, cyst formation, and osteophyte formation. And this patient is showing a full house. On the weight-bearing lateral view, you can very clearly see that there is a huge amount of bony build-up and dorsal osteophyte formation alongside all the other signs that I've just mentioned. Management. The management of hallux rigidus is, generally speaking, non-surgical until a very late stage. This is probably one of my main slides, because what we see when we get referrals of patients with hallux rigidus, we quite like to see many of these conservative or non-surgical management options already tried. That would be a really good thing. At the end of my talk, I'm going to share with you a referral proforma, which I believe you're using at the moment. And I'm also going to share with you a leaflet on hallux rigidus, which again emphasizes all the non-surgical primary care management options that we can give to our patients when they present with hallux rigidus. Some clinicians believe in supplements, and certainly in the early stages, I would definitely recommend to my patients to use or try glucosamine 1.5 grams, chondroitin 500 milligrams, turmeric, and patients themselves come and present articles from Daily Mail and say, "What do you think about this, doctor?" And unless I'm certain that it might be harmful, I will say, why not try that? Because I am a surgeon, I'm not a nutritionist, and it might just be helpful unless it's harmful. Non-steroidal anti-inflammatories, very frequently I would recommend that as a gel if there's any comorbidities to do with gastric reflux, etc. If the patient can tolerate non-steroidals, that might be a very good option, particularly as a PRN after exercise dose or pre-exercise if they know they're prone to pain in their big toe in the early stages. The shoes need to be extra deep to accommodate the swollen joint, with soft uppers and a rocker bottom stiff sole on the lower aspect, the plantar aspect of the foot. This rocker bottom sole is really important. I wish I had gone into buy some shares in Skechers, because earlier on in my career, because I think I would have made a lot of money that way. I believe that Skechers, MBTs, and ASICS trainers are really, really good shoes for hallux rigidus. They have an extra stiffened rocker bottom forefoot sole, and the shoe will do all the walking for the diseased foot. The shoe will do the toeing off that the patient can't do barefoot. So the shoe and the rocker bottom sole is extremely effective and important. If they don't want to buy a new pair of shoes, I will recommend a stiffening insole, to stiffen the forefoot area of the shoe. I often recommend Skechers. In addition, in order to minimize the forefoot overloading, I will always recommend calf stretches to the patient. If I assess for calf tightness, which I do routinely in every patient, I often find that the calf and the gastrocnemius is very stiff, and it does need addressing, because if you stretch out your gastrocs, you will much more easily lead the first stance phase with your heel rather than with your forefoot. And it does reduce forefoot overloading and symptoms in the forefoot. We have also got the option of injection. I would probably not call injections actually conservative management, so I want to apologize for that. I'd probably say that is sort of beginning of interventional treatment. I perform injections in a joint which I think has got mild to moderate hallux rigidus, which is very painful. I will always perform these injections under X-ray, under aseptic conditions, with a fully consented patient, particularly during the pandemic. I will always use a contrast medium unless the patient is allergic to shellfish, because the contrast is iodine-based. I will make sure that I'm in the joint. I will aspirate any excess fluid from the joint and immediately alleviate many of the symptoms. And then I will refill the joint with a very small amount of depomedrone, very often 10 or 20 milligrams, diluted in 0.25% of bupivacaine is what I use. It has been shown in the literature that 0.5 marcaine is potentially damaging to the cartilage. Of course, we know that the cartilage is already damaged, otherwise the patient wouldn't have presented to us, but still we are taking precautions and we use 0.25 marcaine. We use steroid injections, and in some cases we use ostenil or hyaluronic acid, and that can be extremely effective. Budin, I cannot see the chat and I cannot see the question box. Is everything all right? Can you just confirm that for me?
Yes, all going well so far. No
questions. Perfect. So let me just go back. So this is conservative treatment. When we receive a patient as a secondary care referral, I would like to see that some of these non-surgical treatment options have already been utilized, and that the patient has been educated about their condition, and things like Get You Better, any electronic or digitally based patient portal, any MSK collaborative can only help for patient education. I often refer patients to the BOFAS website, which is it's the patient portal for the British Orthopaedic Foot and Ankle Surgery Society. This is a subspecialty society of the BOA, where I am a member. All of us are members, actually. That's our accrediting body. And it has excellent information for patients. I always think that patients, when they come in and they hear what actually is wrong with them, and you explain to them, this is what it is, it's not a cancer, it's not this, it's not that, they're incredibly reassured, and they are quite keen. Many patients are quite keen to try and help themselves. And I think patient education, non-surgical treatment options, proper diagnosis is the key to really good treatment. However, when patients do come in because they have failed this non-surgical treatment options, we are into surgical management. I don't want to dwell on too much on this. You will notice that there's 3 red bits on the slide. So surgical management can be divided into joint preserving surgery. That means we're keeping the original joint, even though it's diseased, because a lot of the pathology is around the joint, and we can help the patient with doing small bits without actually sacrificing the joint. Part of that joint preserving surgery is the dorsal kylectomy. And I will give you some examples and some pictures and see how that's done. So that's what we are offering. When it comes to, my slides. When it comes to joint sacrificing surgery, we are mainly talking about the arthrodesis, which is the sort of terminal stage treatment for end-stage osteoarthritis of the big toe joint. We have got a new treatment option, which is called the Cativa interposition arthroplasty. And some of you might have heard that, and I'm really happy to take questions after this talk on that. I've got a few pictures to follow this. It's an interposition arthroplasty, which has undergone randomized controlled trials, and St. George's and Southwest London surgeons, all of us contributed patients to that trial. and it has shown really quite favorable outcomes for a lot of patients. One of the key requirements to undertake a Cartiva arthroplasty is that the patient still has a range of movement. If the patient is totally stiff and painful, the interposition arthroplasty will just not work. 95% of our surgery, particularly around hallux rigidus, in fact, 100% always, is performed as day case surgery. It lends itself to it with very modern, short anesthetic methods, with a foot and ankle block, with good patient education, with immediately weight-bearing stiff-soled shoes and crutches. All my patients go home, except for serious hindfoot fusions where pain might be an issue, and they might have to stay overnight for patient-controlled analgesia. But other than that, I would say that probably 98% of my patients are day cases. Kylectomy. I mentioned this already. It's derived from the Greek word kylos, which means bump, and the Latin word ectomy, which means taking something out. So we're removing a lump from the foot. There's an example of a patient here where you can see the typical signs of sclerosis, joint space narrowing, and osteophytes. This is the patient in the picture. Patients have given consent for the photographs that I'm showing. You can see the dorsal osteophyte really clearly. This patient has had virtually a very restricted range of movement and a lot of pain where his shoes are rubbing on the osteophyte. The principle of kylectomy is that we are removing a good chunk, up to 25 or 30% of the metatarsal head and the base of the proximal phalanx. That, from a biomechanical aspect, or the theory is that it leads to an improved and increased range of movement in dorsiflexion, which is what the patient needs to function. This is a little burr. This is one of my staples performing minimally invasive surgery. And it is a burr which is introduced. It's 3.1 millimeter wedge burr. It's introduced through a small portal. The operating space is prepared using a small peristal elevator, and the burr is powered by a foot pedal driven machine, which runs at fairly a high revolution with low pressure. It's a really effective method of grinding away that osteophyte. You have to be very careful when you undertake the surgery. I went through some special training, including workshops and cadaver training, but I've now done this surgery probably for, I don't know, 13 years or so, 12, 13 years. And it is extremely gratifying to do the surgery on patients because there is such a fast rehabilitation attached to this. Just to show you a couple of pictures. So these are clinical examples of minimally invasive kylectomy. You can see, I don't actually have an arrow on my screen here, but you can see there is a marker, it's a purple marker, but the actual wound, the portal is red. You can see that because I have marked out with my peristal elevator which axis gives me the best approach with the least soft tissue damage and nerve damage to access all of the osteophyte. We use a small elevator. We elevate the capsule of the osteophyte. We dorsiflex the toe, and I will use my high-speed burr to grind off the osteophyte, and then I will literally squeeze it out. And it looks a bit like toothpaste, slightly pinkish. And then we irrigate the joint, move the joint, and take X-rays before and after. And it is really, really effective and really quite quick. So this is my setup. And you can see how I sit. I'm right-handed, so I'm using the burr. I'm dorsiflexing the toe actively, so not to disturb the extensor hallucis tendon. And I'm grinding away on this osteophyte until I'm satisfied, both clinically as well as radiologically, that all of the lump has been removed. And this is about, you can see the pre-op and post-op. Pre-op X-ray up on the top, where you can see that huge osteophyte wave. Post-op, the osteophyte has been removed. And this is exactly the same patient that you can see clinically on the left side. So post-surgically, that's of less interest now. It's just that, let's say the patient can go around 3 to 4 days, can remove all the bandages, can have a shower, and can start walking around in normal trainers. There is some swelling, and I advise on ice and some anti-inflammatories, but generally patients will get into ordinary footwear within a week. And this is the look at a week, and the patient was extremely grateful and was able to go back to work. This is an example of the Cartiva interposition arthroplasty. You can see on those two photographs what it is. So it's a artificially made type of polymer. It has the same consistency as a contact lens. It's quite thick. It's like a rubbery plug, see-through. You will insert this plug into a predetermined, pre-drilled hole, like a little socket, into the metatarsal head. It is left proud by 2 millimeters into the center of the head. It acts as a buffer between the two diseased cartilage sites. And you can see from the photographs how it is working. And it works by maintaining the patient's range of movement, which is why they need to have a range before you start this procedure, and taking the pain away, which comes from bone-on-bone movements and nerve irritation. So this is the Cartiva. Fusion. Once we have failed with shoes, conservative treatment, injections, interposition arthroplasty, cheilectomy, repeat injections, and the patient is still having severe symptoms, usually a few years down the line, there is really only one alternative, and that is a fusion. The fusion or arthrodesis can be carried out in many ways. I will just show you an example of MIS just because I can, and I've worked on it, I've published it, and it's been accredited. But obviously, there's nothing wrong with doing an open fusion, and even I do open fusions if it's needed. If we do need to apply a plate because of poor bone stock or of previous surgery, a scarring, etc., if metal work has to be removed first from previous surgery, then I do the open fusion. MIS fusion, this is a failure of conservative treatment for hallux rigidus, failure of joint preserving surgery for hallux rigidus. That will get us to the indication to offer the patient fusion, discuss the risks and benefits, and then proceed. The surgical goal is a pain-free metatarsophalangeal joint in a functional position. It's done as a day case with general anesthetic ankle block. I don't use a tourniquet. I use an X-ray. You can see me working on that big toe joint. I prepare the surfaces with the burr. I take out all the diseased cartilage and remnants of bone. Lavage, lavage, lavage. This is my instrument set. And you can see how I'm now introducing screws. You see on that photo on the left top corner, you can see how the bone is being squeezed out, the bone that I've just removed surgically with the burr. On the bottom left, you can see me inserting a screw under X-ray control. And there's 2 screws that I use. We close the wounds with stereo strips, tiny portals. We take an X-ray, and this is the X-ray that is shown. This shows the screw position where we have compressed the joint. We will immobilize the patient in an offloading shoe and wait for this joint to surgically to arthrodese. This approximately takes 6 weeks. Sometimes it can take a little bit longer. So X-rays and the positioning of this patient after surgery, you can see that the joint is really well fused already. Pre-op, again, post-op, these are my fusion cases. You notice then when I say surgical functional position, I don't particularly hyperdorsiflex the toe. Some patients end up with a very much what we call a cock-up toe deformity, because the surgeon felt that if it was fused in neutral position, that they would not be able to really walk. I feel, and we've done some research on this, that a neutral position, which equates to 10 degrees dorsiflexion on a lateral weight-bearing radiograph, is really conducive to wearing heels. And that's particularly important for the many women that we operate on. There's another example here, pre and post. And this is the post-operative clinical photo after fusion, 1 week after fusion, 6 weeks after fusion. You see how minimal the soft tissue swelling is, how minimal the surgical scarring is, and the patients are very happy with that. These are fit flops, not normal flip flops, fit flops. They are stiff-soled sandals, and they are quite good at accommodating those recently operated feet. This is part of our poster that we presented at the British Orthopaedic Association in 2010, where we interviewed many patients on the size of heel that they were able to wear after MTP joint fusion. And the fact that you can't wear heels after MTP joint fusion is a myth, as is that you can't run afterwards, because you can. This is all a little bit small print maybe, and I'm aware that my time is, it's 18:32. Budin, have I got another 2 minutes?
Yes, absolutely.
Super. So perioperative day case, mini C-arm, wound check, offloading shoe for 6 weeks, and then a final check in clinic at 6 weeks with an X-ray, a trainer or rocker or MBT shoe for 3 months, that's 12 weeks. And then we enroll all our patients into the national registry, which is run by the BOA, to all our patients perform a baseline Q1 questionnaire on their outcomes. We then collect outcomes at 6 weeks, 12 weeks, 6 months, 1 year, and 2 years. We have a huge database of outcomes. We're running this through a special amplitude system, which I managed to introduce when I was clinical director for T&O and Orthopaedics, because it comes with a price tag. But it is an essential way of finding out whether we're doing good to our patients, how our patients feel after surgery, and not just in the first 12 weeks, but also way after our discharge of the patient. We are following our patients for 2 years, and we are relentless at it. We're also feeding all our data into national registries, which is extremely important. So I wanted to now, I'm going to stop sharing this, and I wanted to show you a hallux rigidus leaflet, which I'm going to send around after this talk. I'm going to send it to Budin, who may want to, share that with you. So just to, so it's this one. Can you see that, Budin and everybody?
Yes, we can.
Yes. So this is one of our information leaflets, which we have prepared at the Elective Orthopedic Center, an information to the patient providing about their big, painful big stiff toe joint, hallux rigidus or limitus. And I'm not going to go through it because it would be a repetition of my talk, but essentially it gives really good, comprehensive and evidence-based information on what it is. What are they suffering from? How serious is it? What can be done about it? How can we do without surgery? How can we do it with surgery? What will happen before and after surgery? Lots of links and lots of references. And this is, I'm going to send out this leaflet because we're giving it to everybody. And it's one way, and I'm sure it will be included onto various MSK patient portals. So that's one that I wanted to share with you. And the other form that I wanted to share with you was our Southwest London Orthopaedic Foot and Ankle Referral Form. Can you see that? Yes?
Yep.
So this is the Southwest London Orthopaedic Referral Form for foot and ankle. I'm sure you've all come across it before. We developed it in collaboration with everybody in the primary care sector, and it gives us good information about the patient demographics, about their special needs, the reason for the referral was some reference to their past and current medical history and drug history, because that's very important indeed. And then the reason for referral when it comes to foot and ankle. So sidedness of the symptoms, quality of life effect, what kind of treatment they've had so far, which is really important to know. And ideally you want to have ticked all those boxes in terms of treatment they've experienced so far. Then patient expectations, what do they really want? Some red flags, acute diabetic foot, neuropathy, and then some essential sort of the top 8 or so foot and ankle conditions, which we can tick and then see what why we would be happy to see this, because the referral criterion has been met. For instance, if you go into big toe arthritis, here at the bottom of the page, failed conservative treatment. So after all the treatment options that I've mentioned in my talk, if the patient has failed this, we would be more than happy to see the patient and manage them with either injections or an interposition arthroplasty or an arthrodesis. Thank you.
Thank you very much. That's great. We've got one question in the chat so far. What happens to the bone grinded away? Is it left in situ? And that's from Dina. So I think that's.
Hi, Dina. I think are you referring to my surgical technique when I grind the bone away?
I think
yes. So what happens? That's a really good question. So what we do, I go in with the burr and I debride both sides of the joint, which is the proximal phalanx side and the metatarsal head side. I establish fairly flat surfaces, because to make something round with keyhole surgery is really difficult and can be a problem for soft tissues. So I flush the bone out with a cannula, which is remotely inserted from the side of the joint, away from the operating portal, and you flush. I probably get through a liter or so of normal saline, flushing the bone out. After I'm happy that all the cartilage and the bad bone has been flushed out, I will go in one more time with the burr, and I will basically roughen up both sides to expose subchondral bone, and I will leave that bone in, and it will act and serve as bone graft.
I don't see any other questions. Has anybody got any other questions to ask? Please feel free to post that in the chat. And what we will do is we can share that information that Ms. Sott shown you in terms of the information leaflet and the referral proforma, which is mapped to also the GIRFT standards for referral, as well as the ECI guidance.
It would be really great, Budin, if I couldn't find the GIRFT standards that we have worked on in the Friday morning London GIRFT meetings for MSK. I didn't have easy access to it, but if you have got them handy, it would be great to see them. I've got them sort of in the back of my mind, but I haven't actually got them as a table in front of me.
No problem. I'll have a look for those. We've got another question from Nicole. I would have thought calf tightness was more due to avoiding toe off and plantar flexion ankle, plantar flexed ankle.
I don't know. I'm just trying to find that question again.
Have you got it? I can read it again.
Hold on, yeah. Oh yeah, I would have thought calf tightness was more due to avoiding toe off. I'm not sure that calf tightness is particularly secondary to any condition in the foot. I always think of it the other way around. I might be mistaken, but a lot of patients have calf tightness because they have general posterior chain tightness. Sometimes it's related to back issues, the way they're standing, the hamstring tightness, the calf tightness. And I think if they are tight in the calf, in my perception, it will lead to a permanent position of almost like wearing a heel. So you're always on your forefoot. This is what I meant by forefoot overloading, if that makes sense.
There's another question from Ali. For non-operative treatment, if a patient doesn't want to spend money on new goodness, I can't talk.
Yeah, I can see. Actually, I can see.
New shoes or MBTs, and you suggest an insole. Do you just suggest a stiffening insole or anything else more specific?
So I have known older consultants when I was a trainee that would literally advise the patient to cut a double cardboard, basically from a cardboard box, and shape it into the shape of their forefoot and place it underneath the inner sole of their shoe. And that alone would be having a very stiffening effect. So it's nothing particular. You can actually, I often actually refer patients to Amazon now. In fact, I have the Amazon website open in my clinic. And I say, listen, this is what you need. Stiffening forefoot insole. Obviously on the at SWL and at Epsom and St. Helier, we have an excellent orthotics department, and we receive we triage and we accept all orthotics referrals. So if there's an issue in primary care, we are happy to take these orthotic referrals, and a stiffening insole just means just that. It's usually a full insole where the front half is artificially stiffened. However, may I also say that we've got quite a good primary care podiatry service, and in my opinion, they should be helping with that sort of thing.
There's actually a question from Dina. Are you happy to accept private referrals
Yeah.
from a podiatrist?
Yeah, definitely. Yeah, all the time. Yes, yes. I mean, I work quite closely with podiatrists. I work closely with a couple of girls called Sophie and Amanda from the Gate Lab. They're podiatrists. They give me invaluable advice for patients that are insured and can actually afford to see them. But they're also really good in training and teaching, for the NHS, and they do a super, super service.
There's a question from Nicole. Why Skechers shoes? I find them more flexible and irritating versus a stiffer shoe / rocker.
Yeah, I suppose the advantage I see in Skechers, I'm sure that there's various different types of shoe, but when I advise my patients for Skechers, is for two reasons. One, the forefoot part of the sole of the Skechers is really nicely rounded. It's usually at least 1.5 to 2 centimeters thick. It doesn't bend very easily, and the top of it is soft, so it accommodates any dorsal deformity, any osteophytes, and any swelling of the joint. That's why I recommend a Skechers. But at the end of the day, the patient has to try that out, and it's horses for courses.
I don't see any other questions so far. Any other questions from anybody?
Well, I thank you very much for listening. If you have any further questions or any queries about our service and how to access it, etc. I mean, Budin is obviously a really great mediator and great link between us and SWL and the primary care sector. We are really, really receptive to it. We work with a lot of primary care physicians and GPs, and I think any suggestions, even by email, would be very welcome. How to streamline the pathway for our elective foot and ankle patients. Hallux really just is one small aspect of the service we offer, but it's very, very common. And I know that my colleague obviously spoke to you about hallux valgus and bunion surgery is also very, very common. Over the next few months and years, hopefully we will all align ourselves as to what a good treatment pathway for a patient with foot pathology looks like. And that's really all I was trying to do. So thank you for giving me the opportunity.
Thank you very much, Ms. Sott, and thank you to all of you. We will see you again for the next installment, and hopefully we'll have some sunshine to enjoy over the coming week.
Absolutely, I can't wait. Thank you so much, Budin. Thanks for asking me. I will send you those leaflets now. Okay.
Brilliant. Thank you, everyone. Have a lovely evening.
Bye.
Bye.